Let's dive straight into this explainer on high-yield obstetric bleeding and emergencies. We are focusing strictly on Step 2 CK Next Best Step clinical logic, covering everything from early pregnancy loss all the way to postpartum hemorrhage.
Section 1, Universal Bleeding Triage. We start by anchoring our clinical reasoning.
You've got a bleeding pregnant patient. What's your immediate mental checklist? These universal triage questions dictate your entire algorithm. You need to confirm their pregnancy status, gestational age, vitals, bleeding amount, pain level, fetal status, and whether the cervix has been safely evaluated. Gestational age, pain, and maternal fetal stability are your ultimate branching points here. Okay, here is a massive red flag rule. If a patient is past 20 weeks with vaginal bleeding, do not even think about doing a digital cervical exam until an ultrasound confirms the placenta's location to exclude placenta previa. Doing so could cause catastrophic hemorrhage. Section 2, third trimester bleeding. Here, we use the presence or absence of pain to instantly split our differential diagnosis. This is where pain becomes your biggest clue. Painless bleeding, especially with a history of prior cesarean or uterine surgery, you're thinking placenta previa. But if that bleeding is painful, the uterus is rigid and tender, and maybe the hemorrhage is concealed, that points straight to placental abruption. To diagnose placenta previa, you'll start with a transabdominal, followed by a transvaginal ultrasound. For stable patients with mild bleeding, the next best step is observation, IV fluids, pelvic rest, and a planned C-section right around 36 to 37 weeks. If they're unstable or actively bleeding, you go straight to the OR for an immediate cesarean delivery. Now, placental abruption is going to feature frequent, low-amplitude contractions. Because of the high risk for maternal DIC and fetal hypoxia, your next steps are to stabilize the mother, get her in a left lateral position, monitor the fetus closely, and deliver if maternal or fetal compromise occurs. What if you see painless vaginal bleeding directly following the rupture of membranes, and suddenly the fetal tracing shows bradycardia or a sinusoidal pattern? That is vasa previa, meaning unprotected fetal vessels are lying right over the internal cervical os. They need an emergency cesarean delivery, no question. Picture a laboring patient who's had a prior C-section or myomectomy. They suddenly have severe abdominal pain, fetal bradycardia, a loss of fetal station, and you can literally palpate fetal parts. That means uterine rupture. Management here is urgent laparotomy and delivery. Section 3, early pregnancy loss, so we're looking at under 20 weeks. Diagnosis here hinges completely on the status of the cervical os and fetal cardiac activity. A closed cervical os with fetal cardiac activity is a threatened abortion. An empty sac or no cardiac activity with a closed os, missed abortion. Complete expulsion with a closed os is a complete abortion. Conversely, if that cervical os is dilated and they are bleeding, the abortion is either inevitable or incomplete. For stable patients, you actually have choices: expectant management, medical induction with misoprostol, or procedural management. But the absolute hard rule is that any maternal hemodynamic instability mandates immediate procedural management with suction curettage. If the patient presents with a fever, chills, abdominal pain, sanguinopurulent vaginal discharge, and a boggy, tender uterus with retained products, that's a septic abortion. Your immediate next steps are IV fluids, broad-spectrum antibiotics, and suction curettage. Section 4, Ectopic Pregnancy. This is your classic cause of first trimester amenorrhea, abdominal pain, and vaginal bleeding. You confirm the diagnosis with a positive beta-HCG paired with a transvaginal ultrasound showing an empty uterus, an adnexal mass or tenderness, and potential free fluid. Watch out for rupture, particularly in the corneal or interstitial region. That causes massive hemorrhage. Management is strictly dictated by vitals. Unstable patients need immediate surgery. Stable patients, on the other hand, can receive medical management with methotrexate, assuming it's appropriate. And here's where test questions try to trick you. Avoid methotrexate if the patient has renal or hepatic disease, significant cytopenias, an immunodeficiency, is breastfeeding, or simply has an inability to follow up. If any of those are present, default to surgical management. Section 5, Molar Pregnancy. The clinical picture here is completely dominated by abnormal trophoblastic proliferation.
Look for bleeding, a uterus that is significantly larger than dates, extreme beta HCG elevation, severe hyperemesis, hyperthyroidism, fecal lutein cysts, preeclampsia hitting before 20 weeks, and a classic snowstorm pattern on the ultrasound.
You treat this with suction curettage, followed by histologic evaluation of the tissue, serial beta HCG monitoring, and strict contraception during surveillance. This strict sequence monitors for choriocarcinoma, a malignancy that can cause postpartum bleeding and lung metastases later on. Section 6. Postpartum hemorrhage. We're focusing on the immediate diagnostic steps right after delivery is complete. Normal lochia should naturally decrease over time. Passing large clots, soaking at least 1 pad per hour for 2 hours, or having anemia symptoms are major concerns. Postpartum hemorrhage is officially defined as blood loss over 500 milliliters after vaginal delivery or over 1,000 milliliters after a cesarean. You sort your differential instantly by the uterine exam. An absent fundus suggests uterine inversion. Provide fluids and manually replace it before removing the placenta. A boggy uterus means atony. A firm uterus with ongoing bleeding suggests a laceration, accreta, DIC, or retained placenta. Inspect the genital tract for lacerations, especially after a forceps delivery. Retained placenta requires cord traction and oxytocin, followed by manual extraction or a D&C. For uterine atony, you must memorize this exact escalation ladder. Begin with bimanual massage and oxytocin, then give tranexamic acid. Next is methylergonavine, unless the patient has hypertension, or carboprost, unless the patient has asthma. If medications fail, escalate to misoprostol, intrauterine balloon tamponade, embolization, and finally laparotomy or hysterectomy to definitively stop the bleeding.